All right. Okay, as we progress, I want to remind all of everyone here in the auditorium, in case you missed it prior to the last presentation, or those who are live stream, that all attendees, whether here in person or online, will receive an email requesting a reply. That reply is necessary for those wishing to get a CE certificate. Also, with that reply, please indicate the actual name printed out in your reply of how you want that certificate made out. A question has come up online with the book. What portion of the proceeds of the purchase price, of the bid price, is deductible? These books have been donated. There is no cost, so 100% of what you provide in your bid is deductible, and 100% of that goes to the trust. On the online auctions, that I don't have that information. I apologize. I'm sorry. Oh, never mind. The LDN documentary on cancer is still $10,000 are needed to continue that. 2 sponsor chances are left as major sponsors. The music sponsor for 1,500 pounds, approximately $2,500, or as an associate sponsor of 2,000 pounds, approximately $3,000, or of course, you can contribute anonymously. You can go to www.ldn2016.com/cancer. That's ldn2016.com/cancer. For those just joining us now on the live stream, if you want to present your questions to our panel, please email those to questions@ldn2016.com. As I said, this will be our last presentation of the day. Then we'll be dropping the online, and those please stay in the room so we can divvy up those rewards, those winnings from the 50/50 raffle, which of course Claudette, stand up and wave to everyone. Wave there you go. Claudette's still taking money, and if you have a question, please raise it over your hand, and Leo will come and grab your question. Okay. Oh, Dr. Boyle will answer questions regarding his presentation if you email them to linda@ldnrt.org. Again, any questions on the presentation that was just put up from Dr. Boyle, please email your questions to linda@ldnrt.org, and Dr. Boyle will respond to all those questions. All right, let's move ahead. If someone had 9 tick bites over the course of 24 hours 7 months ago, would treatment still be warranted without presentation of a wheal at the sites? Would the treatment be doxycycline, 100 milligrams BID for 2 weeks? Or do you feel that this would be a case for LDN 3 milligrams daily only for prevention of disease manifestation? Is it necessary to stop the... Oh, okay. I think that's yours, Kent. If you want to grab the microphone, please remember, get those microphones close up.
Basically, so it was 9 tick bites? And
9 tick bites over a course of 24 hours 7 months ago.
Well, 7 months ago. But I would still, if it was earlier, I would definitely treat the person with triple antibiotics to get each stage of the Lyme. We find if you just do doxycycline, you might drive it into that cystic round body form. So if you're going to treat, again, it's a little late, maybe I would watch it, but if it was earlier, I would treat with triple antibiotics.
At this point, though, LDN would be your best bet?
I think I'd watch it, yeah.
So is that yes?
I would say LDN, yeah.
Okay, thank you. I don't know who this is directed to. It says, you mentioned with complex immune disorders, you might increase the dose of the LDN higher than 4.5 milligrams. Okay, I don't recall who that was, who presented that.
No, I know. I've treated a number of these lupus and scleroderma and other conditions in the one patient, and they've got better, but I wouldn't have gone any higher than 4.5 milligrams.
All right. Could you give more specifics, and this is anyone, as to how you titrate up the dose, the levels you use, how quickly and how high would you go with LDN? I guess it's basically, would you start at a particular dose, as in 0.5, 1.0, or 1.5 milligrams, and then progress at what rate? Once a week would you change it? Once a day would you change it? Once a month would you raise it?
I mean, I'll answer. I think everyone has a different formula. It's like asking a chef how to bake a cake, but for people who aren't sensitive or I think's not sensitive, I'll just start at 4.5. If they're sensitive patients, what I think they say the sensitive medications start at 1.5, 2.5, 3.5, 4.5 each week.
Okay, so once a week is appropriate.
I think the one thing is the MS patients, you have to go much slower, like half a milligram to 1 milligram. I do have one MS patient that I tried the lower dose. She really only responds at 6 milligrams, which is really unusual for MS, but that's what works for her.
If a patient becomes dysphoric, would you draw the dose back? And if so, how much? Anyone? If a patient becomes dysphoric, would you pull the dose on LDN back? And if so, what amount would you pull it back if you were bringing him back?
I'll usually stop it and then wait till that symptom goes away and then restart at a lower dose,
Okay, would you start at the initial dose or would you go somewhere in the middle?
like 0.5.
Okay. Would you try to lower the dose for any reason later after clinical response is achieved, irrespective of what the condition is? Dr. Cottel?
No.
Please pull the microphone by you, Dr. Cottel.
No.
Okay, thank you very much. We can hear you here, but the live stream really wants to hear you badly. Does anyone here recommend fish oils as an anti-inflammatory agent? If so, what dose of EPA, DHA do you typically recommend? We usually, depends on the condition, but we recommend usually 500 milligrams for 50 pounds, 1,000 milligrams for 50 pounds of body weight on a daily basis.
The study done by a neurosurgeon post-op with, actually after spine surgery, he used 2,400 milligrams of EPA, DHA. 75% of the people were able to eliminate all their non-steroidal anti-inflammatory drugs. So for true inflammation, I really put it at the 2,000 or 2,400. The American Heart Association recommends 1,000 for heart disease.
Okay, this one's probably going to be for Dr. Crowley. As a starting researcher, I haven't been able to find any dosing studies of LDN in humans. Did Dr. Bahari or any of the other early doctors or Dr. Zagon do dosing studies? If they did do any, did they use surrogate markers or clinically important endpoints? And could you say where this person could find those reports? Do you know offhand, Patrick?
Well, I don't think his studies were absolutely kind of fully clinical in the sense that, like a modern research one. But he did have 1,000 patients, or 1,000 people that he measured endorphins on, or a little over 1,000. And 500 were patients, mostly were addicts at the time. And he was using the high-dose naltrexone, of course, in this situation. But that's where it first became evident that he didn't know the dosage, and he had a big budget for research, so he was going up and down to see what would be an appropriate dosage for what patient at what weight and so on. And it was at the lower dosage that the endorphins shot up 200 to 300%, and that was unexpected as far as I'm aware. And he checked it again, and that has been replicated, of course, afterwards in Italy, Germany, and in Japan. So his findings were correct, that at low dose naltrexone, you get a jump of 200 to 300% of your endorphin levels. But how good I'm not I've not done any research, so I can't answer the question exactly.
Okay, thank you. There is a medication used for multiple sclerosis called Gilenya, fingolimod. It is thought to keep lymphocytes from attacking your CNS by lowering the number of lymphocytes circulating in the blood. Can LDN be used in conjunction with Gilenya? Does anyone have any information on that?
Yes, it can.
Wonderful. Dr. Udell, can Dr. Udell be specific and tell what tests he does for GI tract comprehensive evaluation? I'm afraid not all are available in Eastern Europe. Wow, we really are all over the world.
Well, as far as in the United States, the main labs in the United States, LabCorp and Quest, do not do comprehensive stool analysis, and I have to use specialty labs to get that done. Great Plains, there's several of those, Doctors Data, another one, where they evaluate the quality of the bacteria, whether or not there's yeast, and a number of intestinal markers. It's a 5-page report for IgA and other intestinal markers for GI health. That's the specific one you can get. I would just say if you're in Europe that there are a fair amount of parasites that can be picked up if a simple stool test is gotten, at least in South America and Central America. I've picked up a fair number of children who presented with signs and symptoms that we might call autism, that the children had parasites actually, and we got rid of the parasites. We got rid of a lot of especially aggressive behaviors.
Okay, thank you. Dr. Udell, what is your transdermal base of choice? Lipodermal base, EMU, plurionical organogel, such as the PLO, Lipoderm? Do you have a transdermal base of choice?
So the answer is that I tell parents there's two side effects. One is any of the stimulation that they can get sometimes initially, which will go away from the LDN, and the other is a rash. And emu, at least in the last several years, has been the one that's caused the least amount of rash. I don't even remember the last time I had a rash from emu, and as far as absorption goes, I'm going clinically anyway, and it seems to work at that dose.
Okay. Also, Dr. Udell, a number of autistic patients are difficult to obtain blood draws from. Do you have recommendations for tests that do not require blood draws, and which gut health test do you prefer?
Yes.
I think you said doctor's data?
But doctor's data does some. There's a number of specialty labs, but what I want to emphasize to anybody who asks the question that way is you would never ask that question if your child had, God forbid, diabetes or asthma. You would say, I need tests. Okay, I need blood tests, and you need blood tests. And I am a regular doctor too, and I sometimes give some Valium so the kid can get his blood drawn. So he or she can get some labs. This idea that I don't want to be invasive, you already got a problem. You know, the question here is how you're going to deal, what problem do you have and how you're going to deal with it. And trying to answer the question with your hands tied behind your back is not the smartest way.
That's a very good answer. I think we would probably all agree on that. You do what you have to do in order to do what you have to do. Dr. Udell, you mentioned in 1996 autistic children were first found to have high endorphin levels, and that higher levels correlate to worse behavior. Doesn't LDN raise endorphins?
So there's a belief that there's a blockage, that it happens with tryptophan. We think it happens with B12. I'll measure a number of these features in children that are very high. You would have thought that B12 shots help children, and yet I do measure pre-levels just to get baselines, and I'll find very high levels of tryptophan, very high levels of B12, very high levels of endorphins. Doesn't stop me from thinking that maybe there's a blockage along the way, and maybe that's what I'm dealing with, why the kids are getting better that way.
Okay. Would LDN be useful in adults with autism?
I have used it. I use a higher dose in my adults that have autism. The low dose hasn't really helped them much. Again, it doesn't help much for speech apraxia anyway, so I don't tend to use it for that. It's mostly for aggression and for depression and sadness, and it does help, but I usually doses north of 9 milligrams, because I'll try 3, 6, and 9 just because it's a multiple of the 3. So I'll try 3, 6, and 9 for a while, and then I'll go to like 25 because that's half of a pill. So I'll try that too.
This is a question which I think is better suited to the bar, but Dr. Udell, what do you think, and you may or may not wish to answer this, of the CDC employee, whistleblower, William Thompson, who said the CDC lied about the 3.4-fold increase of autism in African American males given the MMR vaccine? What would you recommend for your grandchildren as far as vaccines?
So the second part of the question is reserved for a bar.
Yes.
The first part of the question is I trained in Georgia at Emory, and we used to pick babies up from all over Georgia. And this idea that the reason that they were kept off of the study was because they didn't have actual birth certificates. When you're born out in the boonies in Georgia, you might just not have a birth certificate. And I guarantee the mother knows the day she delivered that baby. Okay, I absolutely know that you could use the birth date and you would still get good answers. That was the reason those children were not included.
My wife tends to forget any unpleasant event, so that may not always be the case.
No, as somebody in the family remembers the day the kid was born.
Okay, Dr. Cottel, I noticed that you seem to titrate the dose up after 1 week. What determines whether you increase further after 2 weeks sometimes? How do we know what dose to start at? And is a morning dose versus an evening dose preferable in your database, your patient base? All those patients responded with amazing results and great cases. Are there patient cohorts where you tried LDN but you were not successful, and what's the hit rate?
Well, that's a lot of questions.
It is a lot of questions. Let's start off with one, with the first portion of the dosing. You continue to titrate after a week. What determines whether or not you do increase after 2 weeks?
So this is where we say that medicine is an art as well as a science. I tend to use 1.5 milligrams a day for the first week on almost everyone. But patients are individuals, and the treatment has to be tailored to the individual, and you have to know them well, what their problems are, and have a sense ahead of time for what might be an issue coming up.
Okay, and that would certainly determine after the 2 weeks your change as well, I presume?
Right, and I stay in touch with them, so I hear from them at 2 weeks.
Well, I heard you say after you have to come back for a 3-week visit. So, all those patients that you had in your case studies, you had amazing results, and they were great cases. Are there any patient cohorts where you tried LDN, but unfortunately you were not successful?
Yeah, there's been a few of those, and not everyone responds as dramatically as the cases that I presented, but the cases weren't outliers. These dramatic responses happen often.
That's good. So what's the hit rate? I guess the hit rate, would that be positive or negative, as the person who presented this question?
So I can tell you that I keep a spreadsheet on my computer, and I have about 150 patients on it right now. I did an informal survey, and I keep track on a scale of 1 to 5, with 2 being no change, 3 being slight improvement, 4 being some improvement, and 5 much improved. And very conservatively, about 70% of patients have at least some improvement, 4 or higher. And maybe 80% if you take out the patients who for some reason dropped out. And of the patients who had some improvement, about a third of them rate themselves as a 5. So it's significant.
Dr. Holtorf seemed to be agreeing with you. Any other professionals up here, do you have a similar data in your practices, similar experiences? Dr. Crowley, you seem to be agreeing. Dr. Weinstock?
In the restless leg syndrome, it's 65% were marked in moderate responders. But, I think we have to take into account with LDN that it's not a panacea. No drug is perfect at all, and we can't present ourselves that way. We have to look critically and look at the statistics. And I think, at least in the published studies, 10 to 15% of patients drop out because of side effects.
And we seem to have very few side effects in general with the LDN, which is real positive, which may be explaining why you seem to be having that higher success rate. Also, it seems to me, with our patient base, and please tell me if this is the same with your practices, that you tend to give a lot of consultation with this product. It's not just that 8-minute visit with the doc, and here's your prescription, and you're out the door. In our practice, I know, and I'm thinking in most of yours, you spend a lot of time with the patients on these. So it seems to be a general consensus there. Dr. Cottel, did your first case of chemist consider discontinuing prednisone after stabilizing the disease with LDN? First case of chemist?
Right. The first case, she was a retired chemist.
Oh,
She
thank
actually
you.
worked for a private pharmaceutical company. And I want to say she was at 4 milligrams a day when she started it, and by the time, a few months later, she had weaned down to about 1 milligram per day, and her goal is to get off of prednisone.
Excellent. Dr. Cottel, again, the first patient, the chemist, was the methotrexate patient. It was a methotrexate DC'd after positive results were obtained.
No.
The methotrexate was continued.
Right. She's waiting to talk to a rheumatologist.
Thank you. By the way, one of the physician groups I get the greatest resistance to using LDN are rheumatologists. I don't know why that is. Skip, are you getting a nod? I'm getting a nod from you back there. I don't have my glasses on, so I can't see your head move that much. Yeah, you have the same experience. I don't know why rheumatologists are so resistant to this. Dr. Crowley, you want to throw your 2 cents in?
Well, the rheumatologists in my local hospital, it's in Waterford in Ireland, they have completely come around to it because they've seen so many people with fibromyalgia, particularly, and lupus, and they have become converts. And they're the first specialists in Ireland to be advocating it in their letters to general practitioners to start using LDN. And they invited me down to talk to the rheumatology team, and there'd be 18 people on that team. So I went down and spoke to them about LDN. And, we're great friends since, and they call me. It's usually the other way around. General practitioners don't get called by specialists very frequently, but they're calling me now. That's great.
Dr. Cottel, you have input?
Yeah. I was going to add that many of the rheumatologists are now becoming more familiar with LDN, but they think it's just for pain, and they don't understand that it's an immunomodulator.
Yeah, that could be it. It's going to be an education process. You sure you're going to retire, Skip? Oh, yeah, okay. Can we use LDN in low doses or ultra low doses to prevent some diseases, or as prophylaxis, especially in highly risky people? Is this something you'd like to address, Dr. Holtorf?
It is interesting. We find like families, and we'll check families who have chronic fatigue syndrome, fibromyalgia, and the kids will have low immunity. So I think it'd be something very appropriate to do in a preventive measure. And measure ultra low dose, we've been adding that to narcotics, and it does increase efficacy somewhat, decrease tachyphylaxis and tolerance. And I think it also looks good with all the scrutiny on physicians with writing narcotics, that you're adding that to it and basically paying attention to the addiction risk. So I think at some point, ultra-low-dose naltrexone will be added to most narcotics.
Can you define ultra-low-dose naltrexone for those in our listening audience?
So generally use 0.002 milligrams. So you need to find a compounding pharmacy that actually can accurately measure that.
Would you recommend that in a liquid or in a capsule?
We just do capsule.
Okay. For Dr. Cottel, how did you use low-dose naltrexone with weaning a patient off of or down from their top dose of oxycodone?
The patient who was on 100 milligrams a day, I honestly don't know. He just came back 4 weeks later, and he was off.
Patient heal thyself. Dr. Udell, why do autistic kids seem to refuse high protein-rich or protein-high foods and only want carbs? And do you ask parents to remove from the diet gluten, casein, dyes, sugars, or other products?
So we do measure the casomorphine levels and glutamorphine levels, gliadomorphine levels in the urine of our children, and these are peptides that represent morphine, and so they are literally addicted to the junk foods. It's not just restricted interests, which they also have restricted interests. I don't think it's so much avoiding the proteins as they would rather have the ones that make them high. And so the way that I stop the parents from giving it is testing them for the morphine. And sometimes they'll say, well, how much can he have? And I said, well, you wouldn't give your 30-year-old morphine once a week, so you wouldn't give it to your kid either. And I test for food allergy panel with IgG, and in little kids, in kids under 6, it is very accurate. When the parents avoid those foods to which they make the most IgG food antibodies, they seem to improve speech and language and behavior.
Thank you. The panel, has anyone treated cerebral ataxia with LDN, and could it help in an advanced case? Cerebral ataxia. Nope, sorry. Will LDN reverse metabolic syndrome, weight gain, caused by medications such as Seroquel, and other psychotropic agents?
I think it's beneficial for weight at low dose and then going up from there. And so with any of these medications that cause weight gain, it's useful.
One of our presenters at the Vegas presentation, Dr. Andre Lev Weisberg, uses it extensively for weight loss and uses it in conjunction with other categories to decrease the compulsion associated with food eating.
Well, you might improve the leptin resistance too. So your leptin will give you the feedback that you're full. Also, anything that's going to decrease inflammation is going to help weight gain. Inflammation will increase your risk of diabetes type 2 eventually.
Okay. How do attachment issues affect the opioid system? I'm not sure I understand that question completely, but if someone has a better handle on it than I do.
Well, the assumption based on the animal studies is essentially that misattuned attachment creates a pruning back of the opioid receptor system, so there's less available opioid receptors, especially in forebrain regions and thalamus.
All right.
I might say to that,
Dr. Udell, please wait for the mic.
a common theme among the kids, the little ones who get it, and you'll see that today with Jacob, is the next day or within a short period of time, the kid says, "Mommy, I love you," and it may be the first time that the child's ever said that to the parent.
That is an amazing experience. So don't make me cry, doctor. Can anyone talk about how adverse experiences in childhood affect adult diseases? Is there any research or any clinical data on that? Do either of you gentlemen want to address that?
I think the first thing we'd want to note is just the ACEs study. What's the name of the author?
Dante Filetti.
Dante Filetti, that demonstrated there's a direct correlation with pretty much all mental health and physical medical issues with adverse childhood experiences. And that was a big study that's been looked at a lot, but not much has been done with it.
Going back intra-utero, actually, Stanford did a study on cortisol levels during stress during pregnancy, and they found that long-term, after you're born, you do have a tendency to have elevated cortisol levels. It seems to have this chronic stress trait related to intra-uteral cortisol levels from the mother.
This may be more of a rhetorical question. When thinking about the half-life of LDN, should we also be talking about the longer half-life of its metabolite, 6-beta nitrexol? I guess it's more rhetorical. What is ozone therapy? I think that's probably for you, Kent. Do you have a brief? Don't you do ozone therapy?
Yeah, we do a lot of ozone. Works well with LDN. You can either do it basically the MAH way, where you take the blood out, add the ozone. Direct ozone may be better. And then there's a new hyperbaric ozone machine that Dr. Rowan's been promoting, which we're going to be getting. So,
What are the chief conditions that it's used for, please?
basically the same as LDN, really infections, immune modulation. There is some direct killing as a thought, I think, most people, but I really think it works more through immune modulation and cytokine production.
Kent, hold on to the microphone, please. How do you clinically check for low body temperature and chronic fatigue syndrome?
Check their temperature.
Check their temperature. Okay, what parameters do you consider that appropriate?
Basically, you use it as a measure of how much better the patient is. We'll find a lot of people with chronic fatigue syndrome, Lyme, have a low body temperature. As they get better, it will come up. Also, it correlates with metabolism, so we'll check people's basal metabolic rate.
And do you prefer to use a sublingual temperature, a forehead temperature, an ear temperature, or an axial temperature?
We just use the oral.
Just oral?
Yeah.
And for an oral temperature, for a core temperature, what do you find then would be a low body temperature?
You know,
I'm expanding
Yeah.
on what this question is for this person.
below 98. I mean, we'll see a lot of people come at 95, but
Okay,
just
thank
below
you.
normal.
Kent, don't give up the mic. This series is for you. Please elucidate the mechanism of action of heparin in CFS and do it in under 30 seconds.
So basically, it looks like an immune activation of coagulation, where these infections cause the body to basically lay down a fibrin level layer on the blood cells, on the vessels. So again, oxygen doesn't get through, hormones don't get through, it's hard to detox. And so the heparin cleans that up, and all of a sudden medications start working that weren't previously working, antibiotics start working. There also is immune modulatory effects of heparin, and heparin does seem to be directly inhibitory to Lyme disease.
Take a drink of water. What blood test and where from to test for chronic? What blood test and where from? I presume that means whether it's vein or artery to test for chronic fatigue syndrome. You mentioned a specific blood test. I'm sorry, I don't understand that first portion of the question.
I think I'm going to put a lab slip up on our site, HoltorfMed.com, and just list the chronic fatigue syndrome panel. But a couple key measures is looking at a fatigue person versus chronic fatigue syndrome. You'll see high C4A, low natural killer cell function, low immune function. If you look at the Quest lymphocyte subset panels, you'll see immune abnormalities, high eosinophilic cation protein with Babesia. So a lot of indirect measures of infection.
All right. We use B12 for a lot of things. Of course, energy is a big one. Can you discuss how B12 actually modulates the immune system, or is it just, it works, do it?
I mean,
They're asking you.
We'll use it at high dose. It I don't know, there were a few studies that I don't think elucidated the mechanism, but we find that it does work.
It just simply works.
Yeah.
Okay. Can you, again, these have your name on them, so they're love letters. Can you briefly go over how the elevated ESR predicted a response in CFS?
And I thought that was a strange correlation with high SED rate in chronic fatigue syndrome, because we typically find low, and low SED rate actually correlates with the hypercoagulability, the laying down the fibrin. So we find actually the opposite.
I don't know if you're able to put this on your website to make it available, but can you provide a more complete reference for the STAR study showing T3 was superior to antidepressant? Or is that something you wanted to briefly discuss here?
Yeah, I mean, it's just you look at a number of studies. The STAR report, largest study done on antidepressants, showed that T3 was a better antidepressant than antidepressants, but it's not mentioned in the abstract, so which is interesting. Another study on bipolar patients, 78 bipolar patients that had tried on average 14 different medications without any benefit, put them on thyroid, 80% responded, 30% on T3, and 30% total resolution of symptoms.
Thank you. Dr. Udell, can LDN be helpful in ADHD patients, in an ADHD patient who has been taking Adderall for 20 years, reduce and eventually stop? Can they reduce and eventually stop the amphetamine use?
I have. There's a syndrome. ADHD is just a wastebasket disease diagnosis anyway. Okay, so they combined attention deficit and hyperactivity, and decided because stimulant medicine helped both those groups of children, that they would call it ADHD. It doesn't mean that they're really related. The ADHD that I see today has a lot of ASD related to it. They have sensory issues, they have core tone issues, they have GI issues, and they have ADHD. In those kids, I will try naltrexone, and I have been, I mean, it's less than 10 times, I have been successful in either reducing the dose of speed or stimulant medication, or getting rid of it altogether, especially during the summertime or when the vacations when you don't need it as much. So it mitigates the side effects of taking those meds.
Dr. Weinstock and Paul Battle, are you aware of a relationship between UV light exposure and pathogenic intestinal permeability? If so, we know that people who live in equatorial regions have much less gluten sensitivity than those living in areas where exposure to UV light is less due to indoor living or fear of sun exposure. Has any study been proposed or done to study the effect of UV exposure to gluten sensitivity? I don't know if Dr. Weinstock, the reason I picked you is because you work with the gut, and Paul, same thing with you. Otherwise, this was actually addressed to someone else.
You know, might have something to do with vitamin D if it truly is a factor. But I haven't heard of that study.
Okay. Paul, do you want to add 2 cents or just say no thank you?
I don't know of any studies, but since vitamin D regulates the barrier, the junctional cells there, I would assume that's what it's really from.
Okay.
And then, of course, there are ethnic risks for celiac disease per se, and maybe that spills over to wheat sensitivity too, where Northern Americans and Northern Europeans have a higher risk of celiac disease.
Okay. You can tell I'm going to be getting glasses pretty soon. What are your thoughts regarding vaccines and autism, Dr. Udell? Do you think vaccines may be the toxic cause for the environment in these possibly genetic predisposed individuals? I have seen a few cases of children who stop talking following vaccination and begin having the behaviors seen essentially with autism. So you referred to the Dr. Wakefield fiasco previously, yes.
Right. So here's my answer to most people who want to sort of make fun of this whole thing, is if your child was in a study where they could go one way, where they would take the regular vaccination schedule that they give today, even if they're sick, they're going to get the same vaccinations. If you've missed a couple of vaccinations, you're going to still get the makeup vaccinations. And even if you got sick in a previous vaccination, we're still going to give you a vaccination. And we were doing a study where we did, that was one group, and the other group was a group that had low and slow. When you're sick, you don't get any, you don't get all at once. And almost everybody would say, I go in the safe group. So that's the answer.
I mean, there was a nice review article, and no one mentions it. Very well done, showed that vaccines increase the risk of type 1, type 2 diabetes, obesity, asthma, and no one refers to it. You know, it's kind of the third rail vaccines, and they also said likely autism with the mechanism. You look at that Th1 to Th2 conversion, and it makes sense, but I know it's a big, controversy, and you'll get blasted for saying anything, but there's a big review study on it.
Can you provide a citation, Dr. Holtorf?
I forget who it is, but I can email me and I'll get it to you.
All right, thank you. LDN appears to be the new penicillin. How can it work for so many conditions? Don't ask that question up this panel. All right. Has C-reactive protein or SED rate been any type of a predictor for how well a person will respond to LDN? For example, high CRP shows clinically better response to LDN. I've seen this in a number of times since I started paying attention to it a few months ago in my patient group. Anyone want to comment on that? C-reactive protein, CRP, or SED rate as a predictor?
I have some experience with this, and I was expecting the markers to go down in a number of patients who got dramatically better, and they didn't.
Okay.
So.
Dr. Weinstock?
Well, it's Dr. Younger's study that looked at those with fibromyalgia syndrome did better if their CRP was high.
So the sicker patients tended to
More inflammation,
the sicker
you're going to get
laboratory
more
patients.
out of an anti-inflammatory drug.
Okay. Sort of a glass, adding an ounce of water to a glass that's this full or this full, how much effect is going to have. You have discussed a lot about cannabinoids and CBD and LDN, but is RSO, Rick Simpson oil, also okay to use when on LDN? I do not know what Rick Simpson oil is. I apologize to the online person who sent this question. Does anyone? It's high CBD? Okay. So is high CBD okay to use with LDN? My opinion is yes. Does anyone else have an opinion on CBD with LDN?
No, I agree. I agree. I don't think it should have any conflict.
And you're from Colorado, so you should know. Right. We stated that every someone stated that every MS patient you've ever seen had Lyme disease. Dr. Holtorf, how do you explain that some patients diagnosed with MS have an improvement in all prior symptoms with LDN only and no additional Lyme treatments?
That's a good question. I mean, it shows the power of LDN if you catch it in those patients. And in terms of treatment of Lyme, we're trying to use less antibiotics and more immune modulatory therapies. So that may point to that.
Dr. Dayton is going to join us, I hope. We just need to bring a chair up for him. A group member was curious about how many patients in the daily audience are medical professionals and how many are patients approximately. In our audience here of patients, it's a very, very small percentage. About 90, as far as we know, about 90% of those online are some type of medical professional. Only about 10% of those viewing this live stream this weekend are patients. Dr. Forster, would you expand more about your daytime use of LDN? Most discussion for the medical discussions were nighttime dosage, whereas it sounds like for MH, daytime is more beneficial.
Well, thanks. I've just become a doctor.
Oh, Mr. Forster.
My experience has been it doesn't have the same effect on hypervigilance and anxiety during the day if you take it at night. The half-life is 4 to 6 hours, so you're getting all the benefit when you're sleeping. Most of my patients have hypervigilance, so it does help them sleep. A lot of them have sleep issues. It's rare in my experience to have sleep problems, though I know a lot of people have that. So it knocks down the hypervigilance as a result of reducing dissociation. As I mentioned, you have fewer opioid receptors at baseline if you've experienced neglect and trauma early on in your life. And we're constantly adding and taking away opioid receptors throughout the day, hour by hour. So it's upregulating, LDN upregulates receptors as well. You have more receptors. Receptors are bound by LDN, and so you're not able to dissociate. And that's mostly a good thing unless you have an extreme dissociative disorder. I'm probably doing more than answering.
Thank you very much. Please discuss strategy when a patient has only a partial response, but higher dose has less effect. Also, please discuss strategy when a patient has an initial positive response, but then, after several months or years, symptoms seem to progress. So I guess the question is, if they're at 3 milligrams or 4.5 milligrams, they're having a less of an effect than at a lower dose. Yes, that would be the first question. Anyone want to address that?
Yeah, sometimes if you take them back down, they do better.
Good strategy. Okay. And then if indeed they progress after years and they seem to then revert their symptoms, where they're doing well and then all of a sudden the symptoms seem to come back, what's your strategy then?
I harass them about their diet.
I'd listen to you. You look pretty ominous. It's pretty tough to me. All right. Please discuss any conditions where you have tried LDN but it helped very little or not at all or was actually negative. Also, are there any conditions for which you believe LDN should not be used so you haven't tried it? Is there anything that you've said, I've tried this a few times, but it just doesn't work?
So I have about 5% of my patients who stop it. I decide whether something works or doesn't work because the parent starts or stops it. You're gonna, if it's an adult, you're gonna stay with stuff maybe 2 or 4 weeks or more. With a child, after about 2 weeks of extreme reaction to it, and even though I lowered the dose, I'm just gonna stop it and say that stuff didn't work. And that's only in 5%. I do have a large percent that it doesn't do anything in, but these children are presenting with multiple other problems.
A lot of comorbid conditions, obviously. Right. Dr. Cottel, in your case study with spinal pain, this was actually, I was interested in the same question. Was there an improvement in structure, as in less curvature, as well as relief from pain?
No.
Okay. To anyone, my sister is also taking LDN for eczema, but has a slight recurrence of rash an hour before her nightly dose. Does this mean she should increase the dose slightly, or is this merely coincidental, or should she decrease the dose? She asked her doctor, but the doctor is new to LDN.
I would increase the dose a tiny bit, depending on where her dose is.
What would be a tiny bit, please? If you're at 3 milligram, for example, what would you go to?
Another 0.5 milligrams.
So go from 3 to 3.5, or
Yeah.
4 to 4.5, or 4.5 to 5 as a maximum dose, even though Skip says never go higher than 4.5.
Well, I didn't say that.
Skip says that.
No, I mean, I didn't say go past 4.5.
I would say add other therapies. Well,
Yeah.
low-dose allergen, a lot of times it's food reactions. Ozone or ozone cream actually works really well, too.
The other thing I did actually with my son is know the T cells on the skin work different than inside the body, and magnesium. It's a magnesium-dependent reaction. When I gave him magnesium, his actually skin rashes and reactions all went away.
This next question is one that I think is actually a pretty common thought or misthought. LDN, in my opinion, is an immunomodulator, not an immunostimulator.
Right.
And based on that, this question comes up really, really often in our practice. Has anyone used LDN in a patient with an organ transplant? I've seen the warning against it, just wondering if there's any firsthand experience. Would it not just modulate the immune system, but stimulate it so it would increase the risk of rejecting an organ? Are we going to stay mute on this one, folks?
Yeah.
Okay.
You don't want to get blamed for anything.
I'm just, okay, then I guess I'm the one who opened my mouth. I'll take with what I said, and I still believe what I said. I have a patient who has had a spinal cord injury where due to a bone spur, it caused his disc to rupture into his spinal cord, causing him to collapse. After 1 year of physio, he states he was gaining his physical capacity back, but started to note mental decline. It was also discovered through the sleep clinic that he had leg jerking. He states it's not RLS. That pulled him out of REM 2 back into REM 1 so that he never reached deep sleep. His main complaints are problems with focus, concentration, and remembering things to do. Can LDN be beneficial for this patient? If so, at what dose? Or would you start at a dose of 0.6 milligrams per kilogram? By the way, he's also a type 1 diabetic, diagnosed at the age of 9. So, since we don't have anyone jumping in, I'll throw some pharmacy information or my thoughts into it. Patient's a type 1 diabetic. It's an autoimmune condition. He very well may benefit from LDN. Would it work? That I think we'd have to find out. Does anyone want to address it beyond my thoughts?
Just about the deep wave sleep. If they're not getting deep wave sleep, everything gets worse. So Xyrem or baclofen actually is shown to increase deep wave sleep, but the standard sleep meds don't.
Paul?
Well, I think some of his sleep cycles from the pain, so the LDN will help with inflammation around the nerve roots, around the neuroforamina, which is probably why, I believe Jill's patient got better because they get intrathecal and injections in the neuroforamina for the inflammation. That helps them quite nicely. So I think that's where the LDN might help them. The LDN, in my experience, I've only had one patient with type 1 diabetes. I would really be cautious of him introducing LDN without really monitoring his glucose, like 4, 5, 6 times a day, because he can get in trouble. He could drop precipitously.
Absolutely. Once a patient gets off LDN, again, we've decided why would you want a patient to get off LDN if it's working? Do the symptoms come back? I think we've discussed this in the past. Yes, they tend to. Does it actually heal the body, or is it merely decrease inflammation? Again, we've seen some reversion of symptoms. It's what's been discussed this weekend, but does it actually heal? Jill, you wanted to comment on that?
I do. My mother had RSD of her hand, and she took LDN for about a year, and she had to stop it for a dental procedure and just never restarted it, and her symptoms haven't come back. And I want to say maybe it's now 4 or 5 months.
I hope it lasts even longer.
Yeah.
Can I make?
Go ahead, sir.
So I've had clients use LDN through their therapy. It assists them in doing their trauma work. That's getting much resolved. They're getting used to having emotions again after a lifetime of dissociating it. Stop LDN. She was doing quite well for quite a while, but then started running into some other problems in her life and resumed it. So I think learning and healing occurs quicker on this drug in many cases. So patients do want to get off it, and they can do it without any problem with mental health issues.
All right. Dr. Udell, which compounding pharmacy do you use that dispenses LDN cream for your patients? Are your patients only in Florida, or are they from around the country, doctor?
No, I have patients from all around the world, thanks to the internet. I'm sure we all do. And to get it from either from their local compounding farm. I haven't seen a big difference whether they get it from their local compounding pharmacy or a big pharmacy. I like the local compounding pharmacy the best,
Me too.
wherever that is. But I haven't seen any big difference from one to another.
But you did comment that you found that the emu oil seems to be the most agreeable
I haven't had
for
a
your
problem
patients.
since emu oil, yeah.
Okay, good to know. Question for any panelists with experiences. Assuming a patient has an intact GI, is the administration of transdermal low-dose naltrexone as effective clinically as oral administration in the usual patient? Most of our patients, if they can take it orally, they have an intact gastrointestinal system, they prefer to do it that way. Obviously, with peds or with autistic children, the cream may be the approach of choice. Any other inputs on transdermal LDN? No? Anything from our audience? No? Okay, thank you very much. My observation is that LDN is a piece of the puzzle, and a motivated individual, a patient, will combine the effectiveness of LDN with other strategies, especially if they listen to Jill, such as autoimmune protocol diet and supporting nutraceuticals, appropriate lifestyle and environmental modifications. Any comments on that beyond what we've said already?
Right, you can't live a terribly unhealthy lifestyle and take LDN and expect to get better.
Okay. I'll see if I can get through this one. I diagnosed a case of MTHFR mutation, homozygous, a 27-year-old male with a childhood asthma, 17 years of gout, uric acid on Ulrich, 25th year, when they became 25, at 17, I'm sorry, I can't continue with that, I apologize. I can't make out enough of it. Does anyone have any experience with LDN in prostate cancer or breast cancer, hormonally based cancers? Anyone? No? Dr. Khan is gone. And did we have 2 cancer? Dr. Dayton, Dr. Weinstock, would you hand Dr. Dayton a microphone, please?
Yes, I've used LDN with various forms of cancer. Today, or yesterday, presented 3 cases where LDN was the only treatment. So it's difficult for me to tease out, the benefit of LDN from all the other things that were done. But I do use it regularly.
Thank you. Thank you.
We had a
Go ahead,
case
Dr.
of nasal sarcoma. I believe she was going to basically get her nose chopped off, was being fitted for a prosthetic, was going to go under chemo. She refused. We put her on low-dose naltrexone, ozone, and some salvestrol. and 6 months later, it's gone.
That's amazing.
Yeah.
As a functional medicine psychiatrist dealing with immune and brain disorders, I quite frequently have observed this and worked to support the free T3 levels, but have been a little nervous about the low TSH and the risk for osteoporosis. Can you comment on the risk for osteoporosis with this regulated transporter system and low TSH levels? Paul?
There's multiple studies, and there really hasn't been any good conclusion that when you administer supplements for supplemental thyroid, it really increases the risk of osteoporosis. Now, people who are hyperthyroid, that's a different thing, but there hasn't been any conclusive studies showing it increases osteoporosis.
My 20-year-old, do you want, Ken?
Yeah, I'll agree with that. Biggest review study showed no difference with suppressed TSH in premenopausal women or women on hormone replacement. Maybe a slight decrease if you're not on hormone replacement or not on vitamin D and things like that. But yeah, the Graves patients are different.
My 20-year-old daughter has had Hashimoto's since she was 9 and developed chronic fatigue syndrome with adrenal insufficiency. At age 13, she has been taking 4.5 milligrams of LDN for the past 6 months, while the amount of T3 she was taking had to be reduced as a result of the LDN. Her TPO has not declined and is still high at over 1,000. In addition, she still battles severe fatigue. Should we see a decline in her TPO, and how much longer should it take if indeed shouldn't we see a decline in her TPO, and how much longer should it take? By the way, P.S., she is in college now and probably does not have the best eating practices. Pull her out of school.
Yeah. So
20-year-old
I think get off gluten, GMOs, look for a chronic infection in there. Will likely. Sometimes it's tough to get the TPO down.
Dr. Dayton, these next ones are for you. Dr. Weinstock, would you give Dr. Dayton the mic, please? Thank you. Dr. Dayton, when you use alpha-lipoic acid in combination with LDN, are you using it IV or oral?
Both.
Thank you. What kind of doses are you using?
IV, about 600 milligrams a day. Oral, maybe 12.
1,200 milligrams daily? Are you using it only for pancreatic cancer, or do you use this in combination with other types of cancer?
I use it for other types of cancer, too.
Can someone go into the reasons to use lower doses for Hashimoto's and why there are cautions about them? I'll take this. You guys want to add on? With Hashimoto's, if you give a higher dose of LDN, they seem to have an overly significant response, and they can get very quickly hyperthyroid. Is that in our practice? That's what we've seen. Ken, is that what you've seen?
I don't see that too much, but I'll generally start lower in those patients and ramp up.
Anyone else want to comment on that? Dr. Weinstock? No? Okay. Someone mentioned with complex immune disorders, you might increase the dose of LDN higher than 4.5. Anyone want to address that? Okay. Can you give more specifics as to how you would titrate the dose, the levels used, how quickly and how high you would go? Jill, I think you addressed that earlier. Would you cut back if the patient becomes dysphoric? I think we addressed that. Would you try to lower the dose later when the clinical response is achieved? I think we also discussed that. Can LDN help a patient who has a pain from a synovial cyst, which formed 2 years after having a laminectomy, to alleviate nerve compression? Did we ask this yesterday? This was yesterday. Okay. Grain-free diets. Dr. O'Brien's gone. LDN and Alzheimer's. How that my notes get mixed in. By the way, thank you for all these questions. We really appreciate it, both in-house and online. Is there a medical explanation for why some CFS patients report that they are super sensitive to medications and say they can only tolerate a very... I remember this doing also. Okay. How can I tell what is the half-life of LDN? No, sorry. I apologize for those. Have you used a combination of LDN and oxytocin? That was yesterday also. Okay. Sorry about that. We need to get a better presenter up here, besides the person as an MC. Okay. I did that already. Mr. Forster, can you clarify that mental health is not an inflammatory condition, please? As a mental health patient, my research and experience has confirmed that many other doctors have stated that this weekend, to paraphrase, the gut and inflammation are at the core of many symptoms, physical and mental, which LDN has been showing to be effective in improving. And I think that was the caveat to the question for Mr. Forster. Can you clarify that mental health is not an inflammatory condition?
Well, I didn't say it's not an inflammatory condition. I said that inflammation is there are often with mental health issues, and there's research demonstrating it, that there's depression has a fairly high correlation with, or there's often inflammation with depression, and it's a factor in a number of other mental health issues. It's well, oxidative stress on the system is probably another issue, but that's common with a number of mental health issues. So, yeah, I'm not saying it's a inflammatory issue, but, well, inflammation's an issue with many mental health issues, is my understanding.
Paul?
Related to coronary disease, depression is one of the highest risks for reinfarction. And depression does have inflammatory components to it. Since you have inflammation, you can release enzymes that release the plaque in coronary disease. So there seems to be a strong correlation with inflammation, depression, and risk of reinfarction in the cardiac studies.
There's also research that SSRIs, after about a year, increases inflammation. Initially, it decreases it.
We've seen many examples of LDN being causing a side effect of sleep disorders. Can LDN be used for insomnia?
Most of my patients have hypervigilance and sleep issues, and yes is the short answer. It quiets the hypervigilance down. They're able to sleep, and it increases REM sleep, because some of these people aren't ever getting into deep and REM sleep. So that increases dreaming and the intensity of dreams for a while. Then they catch up on REM sleep and they're doing much better. If there's a revving up initially, I've had a few patients who rev up on LDN, but that lasts for an hour or two, so they just take it a couple hours before going to sleep.
Dr. Cottel, did you want to add something to this?
Yeah, if chronic pain is the reason they're not sleeping, then it works very well.
If chronic pain is the reason they are not sleeping, then LDN seems to work very well for insomnia. Dr. Udell, at what age can you begin using LDN, and can it be used in infants?
I've used it as young as 9 months, if I really think that there's immune system abnormalities, and also the sibling of an earlier child who responded to LDN and is having similar red flags. I'll give that a try.
It has been mentioned that the source of LDN is important. Can you please address this more specifically? I work with a compounding pharmacist, and I intend to inquire, but need clear guidelines on proper sourcing before doing so. The comment on the sourcing of LDN, part of it was a preference to use American-based vendors such as PCCA or Mediska for the pharmacy. If you're using if a pharmacy is using a legitimate wholesaler, that you're not buying this online, as was suggested in the Claudia Christian presentation, you're probably going to get a pretty good product. And all these pharmacies have to have what's called certificates of assay for their products they get in, and that would guarantee that the product is appropriately of the appropriate strength and mixture. My observation is that LDN is a piece of the puzzle, and a motivated individual, such as the patient, will combine the effectiveness. Oh, how'd that got duplicated? Does the chronic use of opiates, such as codeine, lead to immune suppression? Interesting question. Unfortunately, Dr. Pradeep Chopra
narcotics,
has left, but, yeah.
narcotics are associated with increased risk of mortality and infection in Crohn's patients. So we do think it's inflammatory, narcotics.
Yeah, Dr. Chopra talked about glial cells. Dr. Dayton, would you like to discuss that, please?
Sorry, I would just like to go back to a previous statement I made with the use of alpha-lipoic acid. Have to build up very slowly. Don't start off at the doses that I gave.
Okay, so as opposed to 600 milligrams daily IV or 1200 milligrams.
That has to be built up too.
Okay, and how would you recommend a clinician start that dosing typically?
Perhaps at 200, and over several days increase it to 400. and then go to 600.
And as far as an oral dose to eventually get to 1,200 milligrams, where would you recommend that a clinician typically start dosing?
I would recommend somebody starting at 200, maybe twice a day.
200 milligrams with or without food, doctor?
Pardon me?
With or without food? Does it make a difference?
I haven't noticed any difference.
The reason I ask is that alpha-lipoic acid may also increase glucose sensitivity.
Yeah, cause hypoglycemia.
Okay, so orally 200 milligrams twice a day would be a good starting dose with an end point of approximately 1,200 milligrams daily, and IV 200 milligrams daily for a starting point to ultimately get to a 600 milligram daily IV dose. That's correct. Thank you, doctor.
What side effects do you get if it's increased too quickly?
The question is, what side effects do you get if you increase the alpha-lipoic acid too quickly?
People sometimes have hypoglycemic-like symptoms, shaking, feel a sense of not feeling well.
All right. Thank you, doctor. Is anyone personally using LDN for health maintenance or disease prevention? You guys want to tell personal stories? Okay.
Well, on that topic, Brown and Panksepp have published a paper, I think that was 2008, on that topic.
All right. Please hang on to the microphone. What about LDN and schizophrenia with a patient who has had an extreme case since 19 for 35 years? They're now 55 years old. They had aggression and PTSD are very high and extreme childhood traumatic experiences.
There has been some use of high doses of naltrexone in psychosis that hasn't responded to traditional neuroleptic symptoms with improvements. So that some of those results have been presented at the conference. But
Just wanted to mention with all those schizophrenia, bipolar, very high incidence of vector-borne infections. To watch for that.
Okay, are you using consent forms for every patient prescribed LDN since it is all off-label use? We had this question the other day. Some doctors, I think Dr. Khan is using a consent form. What about in your practices, doctors?
We do every day. Yeah.
So Paul, use a consent form.
Yeah.
Dr. Holtorf?
No, I think if you're going to do a consent form for LDN, I mean it's so safe. I can't imagine how many consents you're going to give for everything else off-label.
Dr. Udell?
Please take the microphone, doctor.
I use consent forms for everything separately. That way
Okay.
we know what they're getting.
Mr. Forster?
No.
No? Mr. Elias?
I'm not a prescriber, so I only deal with a physician who
Dr.
prescribes.
Crowley, I know you don't bother. You say, I'm going to do whatever. You're a cowboy, an Irish cowboy.
Yeah, no, I use consent forms.
Do you really use consent forms?
Yeah. Just one thing, that you mentioned something, motor neuron disease, I wouldn't think is of any benefit, and nobody's messed. That's my experience anyway. Sometime in Alzheimer's, it's worse. People seem to improve a little bit, but I just a very little bit.
Dr. Cottel, do you use consent forms for LDN in your practice?
No, but I document it carefully in the note.
Okay. Dr. Weinstock?
Yes, I do.
Dr. Dayton, do you use consent forms? You use consent forms. Thank you very much. So the consensus in general is that physicians who are using off-label products for off-label uses should probably use consent forms, unless you're, Dr. Holtorf, and he says, psh. By the way, I love having my Irish and Scottish presenters because they're all such good storytellers. No matter what the question is, you get a story. Thank you. This is our last set of questions. Regarding PTSD and depression among veterans, does anyone on the panel know of U.S. VA studies or use of LDN? I'm guessing no. Anyone?
To my knowledge, there's no study with LDN with regard to PTSD or other traumatic stress syndromes, other than the Pope and Waller study that was mentioned.
Yeah, the Papa-Voller study, most of those patients, they had multiple dissociative disorders, but almost all of them had complex PTSD, childhood issues.
If indeed you're going to see a drop in thyroid peroxidase or TPO antibodies, how long does a Hashimoto's patient need to be on LDN before this decrease is likely to occur?
You'll see a drop usually after a couple weeks, and then progressively decrease, and then other therapies and get off gluten. Selenium can lower it about 40% as well.
All right. In the event of this particular clinician has a patient who has Hashimoto's, has been on LDN 4.5 milligrams for 6 months, her TPO is still in excess of 1,000. Do you think it will eventually decline?
I think that one's tough. Again, need to look at other therapies, chronic infections, when they're that high.
Dr. Gilhooly in years past has mentioned about BID dosing with naltrexone, low-dose naltrexone. Would anyone care to comment on that, on BID dosing? No?
I occasionally use it when I think that it's wearing off. The effect seems to be wearing off, and it occasionally works. I mean, I can't tell who it's going to work in and not, but it's better than the next thing that I have to do usually.
Okay. Mr. Forster, I think you actually covered this already, but you mentioned a condition one should rule out before prescribing LDN. Could you explain further what that condition was?
The condition is dissociative identity disorder, DID, formerly labeled multiple personality disorder. And the problem there is if you use it prematurely in treatment, it'll start. DID is essentially, it's a dissociative disorder with amnesic barriers built up so that they don't remember stuff that was too traumatic for them to handle psychologically. Because naltrexone disrupts dissociation, it can break down those barriers prematurely. So they need to be in an advanced stage in treatment before they start using LDN, and they need to start at very low doses. Ulrich, you might have any other comments?
The only comment is that essentially opioid antagonists lift amnestic barriers, and if you lift them prematurely without patient or client being ready, you're looking potentially for serious deterioration in functioning.
So, and if you don't have DID with other hypervigilance, PTSD, other trauma kind of situations where you're walking around in a constantly hypervigilant state, you're dissociating constantly. And so low-dose naltrexone disrupts that concentration so you can be present in the moment. So one way it's been described to me is sort of like instant Buddha.
Okay. If there is a concern of increased immune response or immune modulation in organ transplant, why do we not have the same concern for autoimmune diseases? Why doesn't it further drive the disease process? Once again, I think this gets into that misunderstanding that LDN is an immunomodulator rather than an immunostimulator. Does anyone wish to comment further on that? Or is that sufficient? Okay. If you are in treatment with multiple sclerosis for a dose of 4.5 milligrams for quite a while, and the patient presents a progression of the multiple sclerosis, should you try to increase the dose of naltrexone? It's an interesting question. Would there be, if your patient's been on this for a while, would you increase or would you draw them back perhaps and then see if increasing it later might benefit the patient? Just as a thought.
No, I wouldn't increase the dose. What I find usually that the relapse is usually due to excessive stress, that there's something going on in the person's life, and you should look at other aspects, apart from the MS. And if they deal with that, I don't go above the 4.5, and it usually settles down. Usually the relapse is less than it used to be before they went on LDN. It's not as severe. Definitely that seems to happen. But when you look closely at the patient, there's usually something going on in their lives that they may not have told you about, but it's extremely stressful or it's been prolonged for too long,
I think I would endorse Dr. Cottel's position to investigate diet and other lifestyle and other things you can make changes in.
Can I throw in therapy could be beneficial because trauma, stresses the whole system. You're more vulnerable to illness. You resolve some of these old wounds. You're reducing stress on the whole system and you're going to be more healthy.
Dr. Cottel?
Now, the other thing is I'll find out that patients will not identify a stressful thing that happened to them, and you take them very carefully through their history over the past 6 months, and you can identify it, and they go, oh.
Garbage in, garbage out, clear out some of the garbage, you might clear out some of the other problems. Dr. Holtorf, did you have an input on this one?
I think that really depends on the patient and the relationship with the patient, and how well you explained low-dose naltrexone. So I might go up on the patient, I might go down, I might stop it if I'm also worried about being criticized by their neurologist. So I think it depends.
Okay. Is it necessary to stop LDN during low-dose allergen treatments, such as allergy shots? Anyone? Would it decrease your response? Dr. Holtorf?
The thought is not to do it together, but we will generally stop it, but I think the ones that we haven't, for some reason, seems to work just as well.
So if you'll stop LDN when a person is getting allergy shots, do you just stop it just for the day they're getting the shot, or do you stop it for a longer time period?
Usually a couple days before and then 2 weeks after.
A couple days before and 2 weeks after to stop the LDN around the time the person is getting an allergy shot.
Yeah, for the low-dose allergen, yeah.
For low-dose allergy. Okay. As menopause and andropause are also vascular events, is there any research showing a reduction in adrenal stress and levels of cortisol with the use of LDN? I would think that LDN would lower incidences of hot flushes. Anyone? No? Okay, that is all of our questions. Your panel, you were amazing. I thought you did just an incredible job. I want to applaud you. I want to let our people who listening online know. Thank you. I want to let those who are streaming know the auction for the vacations closes in 12 hours after the conclusion of this conference. They'll be available by clicking